Right. All right. Well, sorry everyone, and let's start again. Um, Thank you, Doug, for the introduction. And I'm going to be talking today about research and its role towards the elimination of disease. Next slide. And to kick off the talk, I'd like to talk about what does it mean to eliminate a disease. Next slide. And for that, we can turn to the World Health Organization, which has thought about the process and the diseases that might be targeted. Right now, there are actually 8 diseases that are targeted by the World Health Organization. They're shown here, and of note, 2 of them are ocular diseases, which is exciting for those of us in ophthalmology. And one of the reasons why many of us went into public health ophthalmology was because we could work on these diseases. Next slide. So the World Health Organization has developed, Taylor, yeah, thank you, definitions for disease elimination or eradication. And I'm going to share them with you now. Starting off with extinction, the eradication of a specific pathogen so that it no longer exists in nature or in the lab. We have no diseases that we know of that fall into that category. The next one is eradication. And actually, Taylor, can you put it into slide mode rather than showing the slides on the side, please? Yeah, there you go. The permanent reduction to 0 of a specific pathogen as the result of deliberate effort. And that means there may be stockpiles of these diseases in laboratories, as is the case with smallpox. Smallpox has been eradicated. There are stockpiles in Russia and in the US. Rinderpest, which is cattle plague, is another disease which has been eliminated. And polio, guinea worm, and now yaws are targeted for elimination. I think it's instructive to reflect on smallpox. Next slide. Taylor, please. Thank you. And the amount of effort it took to eradicate this disease, which required a global effort to identify all cases and find all contacts. There was a worldwide hunt to ensure that everyone who had been exposed were vaccinated. And the hunt for the last case was truly a global and very expensive effort. The last known naturally acquired case was in Somalia in 1977. 3 years later, WHO declared eradication with no more cases. So how are we doing on the other diseases slated for eradication? Next slide. Guinea worm. In 2019, there were 54 cases, most of them concentrated in just a few countries, mostly in Chad. In 2020, unfortunately, some suspect cases have emerged in Ethiopia. There's been a setback to the elimination effort for this disease because of the finding that guinea worm can be transmitted in dogs in Chad, likely due to the fact that they are given fish entrails to eat. This is a waterborne disease. And now they're finding other infected animals in other countries. So although we're down to very few cases, the problem of guinea worm in dogs is going to prove very difficult to solve. Polio is the next one. Next slide. In 2020, there were 169 known wild type 1 cases, and that's up from 33 in 2018, likely due to the suspension of activities from the COVID pandemic. Most of them are concentrated now in Afghanistan and in Pakistan. The type 2 and type 3 have been eradicated. There's just wild type 1 that is left. This disease has also suffered a setback in the eradication program. The oral vaccine, as everyone knows, is a weakened form of the polio virus. It can mutate and it becomes virulent if there are large numbers of unvaccinated children as the vaccine is given out. 23 countries have now reported cases of vaccine-derived polio. The target was 2023 for eradication of both wild type and vaccine-derived polio cases, but this is increasingly seen as unlikely because of the COVID pandemic. There are other definitions, next slide, for elimination of disease. There's the elimination of transmission, the reduction to zero in incidence of infection, and that is what the Onchocerciasis Control Program is heading towards. And then elimination as a public health problem, and that is defined by the achievement of measurable global targets set by WHO in relation to specific diseases. When they are reached, it may be that continued actions are required, but WHO can declare that the disease has been eliminated. And for trachoma, these are, next slide, the measurable targets. There are two of them, and they reflect the two stages of trachoma. The first is the active stage or follicular trachoma, and the elimination target is follicular trachoma less than 5% in children ages 1 to 9 in all endemic districts in the country. Trachoma goes on to lead to blindness caused by trichiasis, or these interned eyelashes you see. And the second target is aimed at trichiasis, saying that cases of trichiasis should be less than 1 per 1,000 population, again, looking at endemic districts. So there's our targets. Let's take a look at what it takes to eliminate this disease as an example. Next slide. And these are what I consider essential elements for disease elimination. And the first is really back to basic science to understand the disease and its determinants. Trachoma is an ancient disease. It comes from the Greek word meaning roughness, and that reflects those follicles you see on the surface of the upper eyelid there. And in ancient times, it was thought that those follicles were in fact the disease. So therefore, the intervention, next slide, was to take this just barbaric set of tweezers and squeeze the eyelid to get rid of the follicles, which probably did nothing more than help transmit the disease because of a lack of basic understanding. Next slide. We now know, of course, that the disease, next slide, is caused by Chlamydia trachomatis, an obligate intracellular pathogen, which is, we don't really have immunity to C. trachomatis, so children can get it over and over again. We know that the blinding sequela is caused by these repeated episodes of infection. The other key factor that we have learned, next slide, is that there's no intermediate host. It is only spread human to human through infected secretions. So we don't have to worry about mosquitoes or flies or other organisms. Next slide. In essence, the life cycle through communities looks like this, where there is ongoing transmission. Children and young adults have repeated infections that leads on this pathway to scarring and ultimately to blindness. But understanding this allows us to understand where we can intervene and what we can do to interrupt this cycle. Next slide. So the second essential element is an intervention strategy that works at the individual and, I would argue, at the population level. Next slide. So we knew that this now is an infectious disease, and we know that tetracycline was effective. The mainstay of the World Health Organization program for trachoma for a long time was topical tetracycline. In the 1990s, oral azithromycin was introduced by Pfizer, a broad spectrum antibiotic that was long-lived, had very long half-life. And that was also effective against chlamydia and proved to be a game changer in the global program. And the question was, well, why was it such a game changer? Since they were both equally effective at the individual level. And it's because of the effect at community level. Next slide. This is a cluster randomized community-based study that was carried out in 3 countries, Tanzania, Egypt, and the Gambia. In blue, you see, for example, azithromycin villages in Egypt, and then yellow is the topical tetracycline villages, same in Tanzania and Gambia. After the round of intervention, you can see a year later where infection fell to in all sets of villages. And what you see here is that for azithromycin and for topical tetracycline, the fall in infection is quite dramatic in these communities. And in fact, the difference between baseline and 1 year later in these communities is most marked for azithromycin. This was the first data to show us that we could use azithromycin in communities. There were very little in the way of side effects and a lot that made this drug very exciting. Next slide. Topical tetracycline was an ointment. It stings, it's messy, it's difficult to apply. You need to use it twice a day for 4 to 6 weeks. And truly outside of a research setting, it's a huge compliance issue. On the other hand, next slide, oral azithromycin is effective as a single dose. It's a broad spectrum, so there are ancillary benefits to these communities because it helped control pneumonia, upper respiratory illnesses, diarrheal disease, STDs. So particularly appreciated by the adults in some of these communities. And we now know also has a benefit against mortality in children. So oral azithromycin became the wonder drug, and it was hoped that a couple of rounds of treatment in these communities and trachoma would be done. Next slide. What we found, however, was that it did work at individual and at population level, but it was going to be a slog to get this to work to the point where trachoma would decrease to 5%. And some modeling work that we did showed that in hyperendemic communities where 50% or more of children were infected with an annual mass drug administration, it was going to take probably up to 9 years before we could push the disease low enough. Not only that, next slide, there was concern that even if we accelerated the intervention, gave 4 6-monthly treatments, and this is data from UCSF, after the last MDA, they followed these communities that had received such intensive dosing, and the infection appeared to return. So clearly using antibiotics was not going to be enough in the control of this disease. And we were going to have to ask questions about what's going on here. The first obvious question is there resistance? Has azithromycin, in fact, become something we shouldn't treat chlamydia with? And so we did a study, next slide, looking at resistance. This is with Tom Quinn and Charlotte Gatos, where we took samples from people who had pre-treatment, pre-mass drug administration, and then looked at those who had infection after we had given them their doses to see if the MIC had changed. And in fact, there was no difference. There was no evidence of resistance to chlamydia. So clearly something else is going on, and that something has to do with the social determinants of disease. And how do we look at that? We look at it through classic epidemiologic studies of risk factors. Next slide. And this is one that we did in 3,800, next slide, preschool children in Tanzania. And these are the risk factors we found: age and being a female child, nothing that we could really intervene on. Next slide. However, we also found that children with an unclean face, next slide, and families that had to walk more than 30 minutes to get water were also at a significantly increased risk of having trachoma. The clean faces was particularly interesting because was this actually the result of having trachoma, or was this a route of transmission, which if interrupted would decrease trachoma? And that led to one of the first of our clinical trials, next slide, in which we randomized communities to receive an intensive face washing intervention compared to communities that did not. And we evaluated clean faces multiple times throughout in both sets of villages, and then looked at the risk of trachoma at 1 year and found that in those villages where we could see the children had a clean face at least one visit, they had a reduced odds of trachoma. And at more than one visit, obviously, it went down to almost half. So this led, along with other research, next slide, to what is now the WHO recommended strategy for the global elimination of blinding trachoma. It's called SAFE, and it is surgery for trichiasis, antibiotics to reduce the community pool of infection, F&E, facial cleanliness, environmental change, to interrupt and to reduce transmission, to keep it low. Next slide. So now we understand the disease and its determinants, the what. We've got an intervention strategy that works at an individual and at a population level, the how do we intervene? Now we need to know who has the disease, where are they, so we can bring the intervention to them. Next slide. So in a classic prevalence survey, we discovered, among as many others did, that the active form of the disease is most prominent in children. By school age, the active form and infection drops off dramatically, and that trichiasis, the blinding stage, occurs mainly in older adults and actually 4 times as common in women. So now we know who has it. Next slide is, where are they? And the answer to this was found through a truly amazing effort called the Global Trachoma Mapping Project. The goal was to use population-based surveys at district level throughout the world to determine where trachoma was in need of intervention. It was costly, 10.6 million pounds over 4 years, in partnership with 53 organizations, 29 countries, over 1,500 districts, 2.6 million persons examined by over 550 trained teams. It was valuable for identifying districts in need of intervention and districts where trachoma wasn't a problem. It is the largest disease mapping project ever conducted. Next slide. And this is the Trachoma Atlas, now showing where trachoma is prevalent. And you can see that about 80% of the known cases reside in Africa. And there are pockets in South America and some still in the Middle East. But most of the focus now is in Africa, particularly in Ethiopia, where it's estimated 75% of the cases reside. Next slide. So we've now answered the question, who has the disease and where are they? As we work through this global program, we need to define, when has the disease been eliminated? Now, I gave you the targets, but I didn't say what do we use to decide when this disease is gone. Next slide. So the WHO criteria for validation of elimination of blinding trachoma as a public health problem relies on 2 epidemiologic surveys. The first one is done to show that in this district, we have achieved the goal of TF less than 5%. And I'm going to talk about the trachoma as the active form. I'm not going to talk about the surgery component at this point. That we've achieved the 5%. Now we stop all antibiotic intervention and you wait at least 2 years and you do another surveillance survey, again, a population-based survey to confirm the absence of reemergence. And then again, the management of the surgical cases. to confirm the absence of reemergence. So this is the problem when we get to the surveillance. And now I'm going to bring you into kind of the issues that we're facing currently. Next slide. And one of the primary issues with surveillance is the clinical disease assessment can be imprecise. Here you see examples of, on the left, diseases that are not trachoma, but have follicles and look like trachoma. And on the right is an eyelid that's got 3 follicles, not 5, which is the definition of trachoma, but graders seeing these 3 can assume that they're just missing the other 2 and call it. So what if your surveillance survey comes back saying, oh, it went from under 5% and it's now 6%? Is that really reemergence? Next slide. Because clinical disease assessment is a cross-sectional tool. We do not know if we've achieved interruption of transmission. For example, what if it is 6%? Is that just noise? Is that part of measurement error? What if your prevalence was 1% and 2 years later it's 4%? They're both still under 5%, but is that suggesting that there's reemergence? Are there other tools that we can use for surveillance? And the answer is, next slide, maybe. We're looking now and people are evaluating the role of a serologic test for antibodies to chlamydia antigens as a potential tool. Now, these antibodies are not protective antibodies. Sadly, they don't protect against chlamydia, but they are a marker that you've been exposed to infection and likely multiple times. The CDC has developed a serologic test for antibodies, particularly to the plasmid antigen. You can test this from a dried blood spot that's obtained from a finger prick. So it's pretty easy to collect in the field. And you can use it on multiple different platforms. Multiplex bead array, ELISA, lateral flow assays have been developed. So this looks quite promising. The first study to examine this was done by us with colleagues at the CDC in Tanzania in a hyperendemic village. And this is the profile of antibody positivity in children. And you can see how it climbs pretty dramatically from the youngest ages, so that by age 6, virtually 100% of these children have been exposed. The interesting thing here is that although you would expect the active disease to start going down by age 6, here you see the antibodies going up by age 6. And next slide. And that's because we think the antibodies are measuring cumulative exposure to infection over time in these children. And that is a very important point. It might be a test for cumulative exposure, so that although we're getting a snapshot, we are seeing, as in this example, that the 9-year-olds have obviously accumulated a lot of exposure over their lifetime, where the 1 to 2-year-olds are only now being exposed and their prevalence is lower. Now, how might we use that? And this is hypothetical. The next slide I'm going to show you, so don't get too excited. And yeah, next slide. The absence or very low rate of antibodies in children, next slide, if they are born after the program has succeeded, would suggest interruption of transmission. And you can see that now in this hypothetical example, 6 years ago, the program, let's presume it's a highly successful program, was very successful. And by age 6, it started to depress transmission. Let's say that 3 years ago, they determined that TF was now less than 5%. They stopped it. And you can see that the children born after MDA or mass drug administration have basically not had any transmission. So this becomes a very nice signal if we can show that that's what happens. Well, first of all, we had to decide, is the antibody test very reliable? That's the next slide. And these are data showing from Charlotte Gatos's and Tom's lab that testing on the same samples at the same time, highly reliable, tested 5 to 12 months apart, again, highly reliable. Are the antibodies actually as long-lived as we hope they are? Next slide. And this is from a longitudinal study of over 2,000 children, where about 30% of them were positive at baseline. And after 1 year, we do see some loss. We do see some seroreversion. It's about 6% of children lose positivity to antibodies. Obviously, this is an active district because we are seeing ongoing seroconversion in this longitudinal study. But the seroreversion is not at random. Next slide. And you can see that the rate of seroreversion occurs almost exclusively in those villages where the prevalence of TF in the community is exceedingly low or non-existent. In other words, without that constant stimulation, we do see that there is evidence of seroreversion of antibodies. So what does data look like actually in the field, in communities? And for that, I'm going to share with you data that are surveillance surveys done in Tanzania 4 years after they stopped drug administration, and from Nepal 2, 4, 8, and 10 years after they stopped mass drug administration. Next slide. And you can see the top district, Kilosis from Tanzania. In all cases, all of those districts have, again, have TF less than 5%. There's hardly any infection rolling around, just occasional infection. And seropositivity is very low, 7% or less, suggesting that not only have these districts eliminated trachoma, but that we have some idea, at least using a particular platform and a particular way of detecting seropositivity, that low levels do indicate the absence of transmission. But have we ever used this tool to see if there's reemergence? Next slide. And this is a study we just completed. It was a cross-sectional surveillance study 2 years after mass drug administration in a formerly hyperendemic district. So this district back in the 80s was 60% of children with trachoma. But right after MDA, about 6 months after MDA, the prevalence of trachoma was less than 5%. So they stopped MDA and they now went into surveillance. We examined 2,400 children from 50 villages. We did a field determination of trachoma, photo determination. We took an ocular swab to test for infection using Cepheid. And we took a dried blood spot test for antibodies against chlamydia antigen via the multiplex bead array. And what did we find? Next slide. We found that TF had reemerged to 7%, that it went down with age. So the first thought is, well, do we believe this grade of TF? Fortunately, we had done photo grading as well. We took images and the agreement was very good, not suggesting that there was overcalling or undercalling of disease. The correlation between follicular trachoma infection was as good as is seen anywhere else. A quarter of the children with TF also were positive for infection. That's, by the way, not unusual because the clinical signs persist even after infection has been cleared, versus 1% in those without clinical signs of TF. And the seroprevalence was about 18% and increased with age. Next slide. So if you look at that, you say, well, what is this telling me? Oh, Taylor, you jumped the gun here, but that's okay. Ignore the red circle for a minute and just look at the fact that this looks like our age-specific prevalence curve from before. Certainly the 7, 8, and 9-year-olds do not tell us very much. They tell us that there was a lot of trachoma 7, 8, and 9 years ago, and that these children had a lot of exposure. What's interesting are these 1 and 2-year-olds that were born after trachoma was supposed to be eliminated. And the fact that they have almost 7% seropositivity tells us that there is still ongoing transmission. Now, that was shown to us by the rates of TF, but this also provides further data and important data that suggests there is ongoing transmission in these communities. So we are excited about the potential use of seropositivity, and that is being looked at as a tool that could be used for helping countries decide if there is true reemergence in their districts. Well, let's take a look at where we are. Next slide. In terms of the elimination of blinding trachoma. Next slide. We've got a lot of successes that we can point to. Trachoma is down from the second leading cause of blindness to about 6th place. There's good evidence that the number of trichiasis cases have decreased. There's been a lot of surgical effort that's gone into that. Many countries have declared or they're applying for certification of elimination. They're shown here. And there's steady progress towards elimination. They hope for now, initially it was hoped that by 2020 we would achieve that, but that didn't happen. But we're on target now, we feel, to make 2030. The real difficult countries are left. Those are the conflict countries. It includes Ethiopia, where the bulk of cases still remain, but there's ongoing progress and hope that that target can be achieved. So next slide, I hope that I've shown you how research, not only clinical trials, but population-based surveys, case control studies, longitudinal surveys have helped in the fight towards the elimination of a particular disease, in this case, trachoma. It has been the bedrock of a roadmap that has provided what is the disease, how is it, how can we eliminate it, who has it, where are they, when can we declare elimination? It's been a cycle of bench to bedside to populations, and now with seropositivity, back to the bench side and back out to populations in this loop that is essential for us to move towards elimination of disease. And my hope, next slide, is that trachoma will become the first avoidable cause of blindness to be eliminated from the globe. And I would like to just go through the next slides, couple of slides, because I would like to thank all of my colleagues, friends really, who over time have been part of this long career in public health ophthalmology, including my international colleagues, next slide, who have been part of the team effort in this. And finally, last slide, with a lot of gratitude to students over the years who have probably taught me as much as I've ever taught them. It's been a privilege to be part of their learning process. And with that, I thank you for your attention, and we can open up for questions or comments.
Sheila, I'll stop screen share here. Is that okay?
That's fine.
For discussion? Great.
So I'll start with a question, Sheila. You said we don't have immunity and we can get reinfected, but we have all of our disease in children, our active disease, which must mean that somewhere along the line, we're getting some form of immunity that prevents active infection in adults. Do you have any comments about that? Or are there any data that enables you to understand why, if we don't have much in the way of immunity, we don't get active infection in adults?
Yeah, I probably, fair enough. What we know is that the antibodies secreted in tears are pretty ineffective. I mean, we'd hope they would be neutralizing, but they're not. There does seem to be some cellular immunity to this disease. But what's clear is that adults who can still get this disease again. And we know from genital infections that people can get it over and over again. So it's partly the fact that they are less likely to be exposed in the same kind of tight-knit way that children are exposed. But there is some evidence of at least partial immunity as you get into adulthood. That is the case. Otherwise, I think we would not be still looking for a vaccine against chlamydia, which to date hasn't been as well. Let's put it this way: we don't have one on the immediate horizon. So I would say we're not certainly relying on a vaccine to achieve this target, and there is concern again about interrupting transmission as a better way to control this than relying on immunity.
Good. Other questions, people?
Yeah, Sheila, thank you. It's a great talk. In fact, I'd love to get you to come talk to our disease control program students about this. It's fantastic. I wanted to ask about, have people thought about doing sort of a longer term version of the community mass treatment so that you sort of bring a whole generation of kids under that before you then stop, so that a longer duration of that program would potentially lead to not reinfection, recrudescence of the disease?
That's a good question. And in part, and of course, Pfizer is worried about this and others are worried about the fact that although chlamydia has not shown resistance, strep and staph have shown, and particularly strep pneumoniae has shown resistance develop pretty promptly to azithromycin. In the context of treating just once a year, it looks like it's a temporary resistance that children rapidly repopulate with susceptible strains. There's ongoing work to make sure and monitor that we don't develop resistance over time. But the point is the feeling is that as soon as you feel you can, which is TF less than 5% in kids, you stop the antibiotic pressure and see if you're done. And for most countries, most districts, that is an endpoint that has worked. It is only now, and I'll point to Ethiopia. There are districts in Ethiopia that have undergone 12 years of mass drug administration. There are children who started at age 10 who are now 22, and they have had antibiotics there for that long a span of time, and they are still not able to drop the disease. Why that is unknown. There's actually a lot of research now. It's not due to resistance. That seems pretty clear. And why they can't make inroads against this at this point. Doesn't seem to be a particularly virulent strain. Doesn't look like anything different. Why that is unknown. And there are now clinical trials underway looking at potentially providing a single dose followed in 3 weeks by another dose to try to remove it. I don't think there's a lot of stomach for keeping these districts on it for any longer than they have to. But just based on the fact that if it's not working, and that's why these kids continue to be under antibiotic pressure, then what else is going on? We need to do something else.
Sheila, this is Charlotte. Wonderful presentation. I'm wondering if you can comment on what you think the importance of flies and the mothers' gowns and robes that they use to wipe the eyes of children, and whether or not this might play a role in some of the ongoing transmission.
Yeah, so early on, in fact, very early on, there were some very interesting studies done in Iran that showed that a particular type of fly, Muscus sorbens, which is an eye-seeking fly, would hop from children to children and the opportunity for them to be physical vectors. Obviously, they're not necessary, but could be vectors for transmission, was born. And there was a study that was done early on in the Gambia. I have to say it wasn't terribly well controlled. It was an unmasked trial where they instituted fly control measures and showed that trachoma decreased in the villages where there was fly control compared to none. We duplicated the study, but we masked the, we took photographs so we could mask the graders as to the status of trachoma. And we did it in Tanzania, which had a higher rate of trachoma, and we didn't find any impact of fly control. Dropped flies dramatically. I mean, we got rid of flies in the villages where we were spraying, but we didn't see any decline. And we think it's because there are, as you say, multiple routes that take over. When you get rid of one route, like a fly, then there are other ways that children can get trachoma, both by playing together and their hands get dirty. The mothers wipe the children's faces. We found, as you know, because you guys did the VCRs, we found evidence of chlamydia on bedposts, on mothers' gowns, on the necklines of mothers. It's a pretty chlamydia intensive environment. Are they capable of actually transmitting infection? That we don't know. Is there a sufficient dose? We don't even know that for the flies. But the fact that it's there, the fact that it's not just confined to hands or faces, suggests that there are multiple ways in which this is transmitted.
It's great. Certainly part of the environment part of face is safe.
Yeah. Oh, there's a hand up.
Yeah, this is Xiang Rong. It's very
Hey, Ron, how are you? You're trying to get a grant in. Thank you for coming.
yeah. I had Kevin sitting for the first few slides before he went to school. He was very impressed. So I always had this question, and I have worked in Uganda there, and you show the map of disease burden, and East Africa certainly has higher burden there. But now in every country there, and Tom is here, can talk about the situation in Uganda, which I think is very low there. And so I've always been wondering why there is this regional level high variation there, and whether there's any kind of social economic situations that have been considered, and whether interventions there.
Yeah, that's a really good question. And in my view, there are two elements that are necessary for trachoma to exist. One, you need the presence of chlamydia, ocular chlamydia, in order to have it exist. So you can have terrible environments in terms of socioeconomic status, for example, in areas of Latin America, but there is no ocular chlamydia in which trachoma can flourish. The second, though, is it's not enough to have that strain or to have chlamydia. You need to have an environment that allows this promiscuous transmission to occur. And so both elements must be present. And we can take the example of the Gambia, which back in the 80s had active trachoma. And then Gambia underwent a program where there was a lot of community directed development of water supplies, roads, sanitation, etc. Same story in Nepal. And it seems as though those kinds of efforts actually led to the elimination, along with, in the Gambia's case, they instituted mass drug administration, but it had such poor coverage that nobody thinks that the antibiotics had much to do with the actual elimination of trachoma. So when you point out quite rightly that there are countries in Africa that don't seem to have this problem, Uganda being one, there was actually mapping done in Uganda. There was a problem, and I think it was up in the north. They went through 3 rounds of mass drug administration, and they're now waiting to finish their surveillance surveys. It looks like it's gone. So the environment in some of these places is just not conducive to ongoing transmission. And when that happens, then the bug just dies out because eventually it does. And I'm sure Al could speak to what happened in Indonesia where it used to be endemic. And I think, right, Al, by the time you got there, all
Yeah,
those
that's
owners
absolutely
just-
right. The little story is that we were able to hire about 200 former eye nurses to work on our vitamin A studies because they had been trained to do nothing but trachoma work 20 years earlier, and trachoma literally disappeared from the country, and not because of an intervention program, presumably because the basic socioeconomic status had improved quite markedly.
Hey, Sheila, that was an outstanding presentation. It was actually very gratifying for me to hear you do the whole historical perspective, bringing it up to today. So my question is today. So you just showed data from Congo, 7% positivity in the 2-year-olds.
Yeah.
You know, how are they reacting to that? What is the government and your collaborators planning on doing? They're going to redo an MDA for how long?
Yeah.
I'm just curious what the plan is.
Well, this is, of course, viewed as it is in other countries as a setback. You know, they hoped they were done. They are planning. And one of the things you'll notice is that it didn't come back very far. I mean, it's definitely come back, but not far. So that district is slated for another round of MDA to see if that can drop it enough. I think, to be honest, there needs to be a dialogue about what we are going to do to define reemergence, because we cannot get stuck in this cycle of it comes back to 6%. We do an MDA, we find it's now 5%. We wait another 2 years, we look and see. I mean, this is endless. We have got to say and get data to tell us, and I think that's where the serologic data is important, that yes, this is reemergence. We need to reinstitute a program here. We need to be serious about looking at what we're doing with the F&E component, as opposed to Malawi, which, quote, found a surveillance survey of 5.5%, and they're doing the same thing.
Huh. Okay.
Is that really reemergence, or is that within confidence intervals of, you know, less than 5%? So I think right now the national and international programs are flailing a bit in terms of defining when do we reinstitute a program. And if there is anything positive, and there's not much, as we all know, around this COVID epidemic, it's the fact that all program activities stopped for this last year. Everything stopped. And so we have an opportunity, rather than run in and do MDA, to go back to these districts and actually see, is that 5.5% now back at 4%? Is this really noise, or is this really something we should be concerned about? And I think that's, you know, the countries are eager to be done. They want to declare. So they're really pushing to get in there and do mass drug administration. They don't want to do another survey. Whereas those of us that, you know, are researchers that and quite properly don't have the final say in these countries are saying, why don't you just find out if it's still a problem? So the battle goes on.
So Sheila, couldn't you modify your definition of emergence to include that it has to increase by a certain amount to a level above 5%, and the increased amount has to be above the variability of the test?
That's exactly what we're arguing. You are exactly right. And it's not, that's under discussion, I think, at this point, but the country programs are interpreting it literally. You told us the definition is less than 5%. I'm at 5.5, I'm above, therefore X. And in order to have traction in the countries, the World Health Organization has got to come out with a statement that, yes, we want you to be below 5%. We will not consider reemergence until X, Y, or Z happens. I absolutely agree with you. And that's the current status.
Well, it's 9:30. We did have some glitches to start, but ultimately it ran quite smoothly. Sheila, thank you very much. It was a wonderful talk. I think everybody has really enjoyed it. And it's really a great way to start our 2021 seminar season. So great job and thank you very much.
Well, thank you for being so patient. I apologize for all the glitch at the beginning and look forward to the next series of talks. Thank you very much.
We had about 36 attendees today, so thanks everybody for tuning in. I'll end the recording now.
Bye-bye.